This conference will now be recorded.
All right, hello, gentlemen and ladies. We are on June the 1st, and
I can see what the names were there. They're no longer there. I don't remember them.
if you're not talking, it would be good to mute so that we don't get the background noise. We just got somebody talking over. It's June the 1st. This is the high-risk recurrent advanced prostate cancer group. And I'm going to do a quick roll call just to make sure I did get everybody. And we have at least 2 new gentlemen who haven't been with us before who we'll kick off with. And then we'll do a roll call after we've gone through the new gentlemen. That way, if anybody joins us during this time, we will catch them at that point. So here's who I see. Robin, Joe Merger, Jerry Pelfrey, Jake, Russ, Sylvester, Peter Kafka, Joel Lanchette, Les, Paul Frieda, Scott Hogan, David Muslin, Steve Anata, Rich Jackson, Larry Fish, Barbara, and Carl Foreman. Did I miss anybody? Dennis Correia? Oh my gosh. Dennis Correia. How embarrassing is that? Especially since I called him out early in the meeting. Oh dear. Okay. Thank you, Dennis. That's why I do the roll call. And if I seem a little discombobulated today, it's because my main man, Len, has sent his apologies to all of you, his regrets. He is reestablishing himself in his summer residence in Danbury, Connecticut, and just got back after a very long journey. They left yesterday from Venice, Florida. And so I have ably deputized our board chair and moderator of lead moderator for the low and intermediate risk group, Peter Kafka, to step in and help me out. And of course, we have Jake taking care of all of the go-to meeting technical aspects, as always. Right. So what we usually do, Robin and Joe, is that we ask new men to take a few moments, if they're comfortable in doing so, to introduce themselves, tell us a little bit about their background and what brings them to the call and what specifically they have on their mind that they'd like to bounce off this august brains trust that we have here, most of whom have their video or have had their video on. And I will just make a small remark on that it is amazing the difference in video icons that we are seeing over the past 3 months as a result of COVID-19. So most of you remember, Sylvester especially, that 3 or 4 months ago, we would see Sylvester, we would see, sometimes we'd see Jake, we'd usually see me, we'd sometimes see Peter, and there were a couple of others that were pretty good about using their video, but Carl was, but not everybody. And now all of a sudden, everybody has their video on, which tells me that one of the impacts of COVID-19 was to made people much more comfortable with these video chat platforms like GoToMeeting or Zoom, and that when you put your video on, the computer doesn't actually bite back, but we see who we're talking to, and it creates a a much nicer and better sense of camaraderie and brotherhood in the group. And by the way, this just led me into this. This was a segue that I wasn't intending, but I am actually going to do a 1-hour webinar on Thursday on virtual meetings and virtual support groups for WeGo. And if you want more information, it's on our Facebook site and it's on the Twitter site and in other places. So, all right. With that said, Robin, would you like to, if you're comfortable in doing so, would you like to give us some background on yourself and tell us how come
Yes.
you're here? Thank you.
So I've had prostate cancer since January 2018, and I've had different treatments, some pills, chemotherapy. Now I'm on a clinical trial at UCSF, and I'm just here to hear other people's input. I don't have anything really special to say.
Tell us a little bit about your disease history and who's treating you at UCSF, because we know the UCSF folks pretty well on this panel.
Dr. Fong.
Ah,
Dr. Fong,
well,
yeah.
we love Dr. Fong. And when you next see him, you tell him that Rick said hello.
I will.
I have personally a very long history with Larry. And he's on our advisory board. And if you go to our advisory board and look at the picture of him there afterwards, it'll make you smile. It's a wonderful picture with a patient who was a dear friend of mine. And so I get a little choked up when I think about it. But yes, we love Larry. What trial are you on with Larry?
It's a Harpoon. It's called Harpoon.
Yeah, tell us about it.
I go weekly and I get an infusion weekly
Mm-hmm.
for about an hour.
What are you getting? What is it that you're getting, Robin?
It's supposed to increase the immune system.
Okay. Do you know the name of the drug? Do you remember?
Harpoon.
No, the name of the drug.
No, I don't. I'm sorry, I don't know the name of the drug.
Okay. Well, we can look that up. We'll check that. And how when you were diagnosed back in 2018, were you metastatic?
Yes.
Okay. And so
It's gone to my bones.
Okay. And what treatment did you do right away?
I did Lupron and Zytiga.
Okay. And then and how long did the Lupron and the Zytiga work for?
I'm still taking Lupron.
Right.
Zytiga was about a year.
Okay.
Then I had Taxotere chemotherapy.
Right.
And I had another chemotherapy, but I can't remember the name. It's a very long name.
Cabazitaxel?
What's that?
Cabazitaxel.
Could be.
Yeah.
Yeah,
Jeff,
maybe.
yeah.
I went to MD Anderson. MD Anderson gave me another chemotherapy.
Okay. Okay. And
then I went to Xtandi.
okay.
And now I'm doing this clinical trial.
And who was your doctor originally? Were you always with? You say you're from Northern California, right? From where are you from?
Yeah, Dr. Monterey.
Okay.
So my main doctor is Dr. Kuntz.
I don't know. Is Dr. Kuntz at UCSF?
No, he's at Monterey's Cancer Center.
Okay. Well, you've seen some pretty good. And what made you go to MD Anderson? We have a few guys who are. Jim Ward who's on this call right now, goes to MD Anderson. What made you go to MD Anderson?
We just heard that they had the possible other treatments that were available there.
We
just wanted to check out all the possibilities.
Who do you remember which doc you saw at MD Anderson?
Yes, I do. Dr. Korn.
Another one of our favorite docs, Jim Ward sees him. We like Dr. Korn very much. Did you?
Yes.
I hope you did. Did you like Dr. Korn? Maybe you didn't like him.
I did. I did like him.
He is a wonderful and very caring doctor. And
yes.
One of our board members, who is not on the call today because he traveled yesterday and he's doing chemo, sees Dr. Korn. I will tell you that between Paul Korn and Larry Fong, and I'm not just saying this, you have two of the smartest and most compassionate genitourinary medical oncologists that I've worked with since I've been doing this, which is about 13 years now. I mean, they're both pretty amazing. Both Paul and Larry are both pretty amazing doctors.
They are.
Yeah. You're very, very, very fortunate. How old are you, Robin?
65.
Okay. All right.
The drug it's Harpoon is the name of the company, Harpoon Therapeutics.
Yeah.
HPN 424. That's all I can see. And it's to stimulate. It's a weekly injection. It's trying to stimulate T cells. And it's in a phase. Was in a phase. You're in the phase 2 trial. Is that right, Robin? Or is it still phase 1?
I think so.
Yeah.
I don't know if it's phase 1 or phase 2. I think it's phase 2.
Phase 2 to try to determine the dosage. Yeah, it's pretty experimental. Doesn't say how many people are on it, but it's called Harpoon Therapeutics.
Yeah.
Great.
I put a link in the box to the phase 1 trial. I didn't find anything on stage 2.
Thank you, Jake. Thank you.
Rick, I'd like
yes.
to ask Robin, what was his PSA and testosterone level, when he started, and where is he at now?
Good question.
It was about 320.
Wow.
I don't know what it is now.
PSA?
I haven't had it tested for a while. It's about 60 maybe. I don't know what it is. I haven't been tested lately. Go ahead.
Your PSA was 320?
Yes.
Okay.
What is the lowest that it's got to?
It's gone to where it was -0.
Oh, okay.
Wow.
Okay. Was that on the Lupron and the Zytiga that you got down to 0?
Yes.
Okay, excellent. And do you have any pain, Robin? Do you have any bone pain?
Not right now.
Good man.
I don't.
Okay. So let me throw it out to anybody that might like to ask Robin any questions, first of all, and then we'll go back to Robin to tie it up. Any questions from anybody?
So Robin, your first chemotherapy, is that what they tried first?
Couldn't understand you. What'd you say?
Was your first therapy chemotherapy?
Because
No.
my husband
It was Zytiga.
were. Yeah, and how extensive were the bone mets when you were first diagnosed and now? In other words, were they all over your pelvis? Were they going in your, and did they increase or have they stayed the same?
I can't answer that.
Hold on one second, Barbara, because we're still with Peter. So, Peter, your question was,
regarding the chemotherapy, did you do 6 rounds with docetaxel and anything else?
Yes, some radiation treatment.
Okay.
okay,
That was just for a specific slide.
okay. So you did a little, so you did have a little radiation treatment. You did 6 rounds of chemo. And then you did a second chemo, maybe cabazitaxel, but you're not sure.
For some pain. Right. That sounds right to me.
Okay. Now, Barbara was
That was what was that was recommended by Andy Anderson.
right, right. Barbara was asking about the extent of your metastasis. Do you have any idea how extensive your metastasis was?
No, I don't. I can't
Okay.
answer that.
Okay. So a couple of things I think I would say is that some of this information is just good to know. And we would encourage you to know it because we want you to be your best advocate. And so just having a working knowledge of some of these issues is going to be very helpful to you. Do you advocate for yourself or does your wife advocate for you?
My wife advocates for me.
Ah,
Yeah.
well, how come we're not seeing her in the picture as well?
She just left.
She left.
Her name is Robin. I'm not Robin. I'm Joe.
Oh, you're Joe. Okay. Well,
But it's okay. I can go by Robin.
that's okay. We'll call you Joe. Well, yeah, we'd like to hear from your wife one of these days because it sounds like she's the expert when it comes to your disease.
She takes all the notes.
That's what I thought. I figured that one out. And and you tell her she's very, very welcome on this call.
Okay.
Isn't that true, Barbara Discant? Is she very welcome or not?
Well, all I say is I've been very welcomed by all of you, and I would absolutely love to meet her on this call if she wanted to do so.
Okay.
Right.
Well,
Right.
so we'll now, Joe, do we have your email address or how did you find us, first of all?
I think I found you through a friend of ours she's a therapist, and she knew of you.
Okay. If you can give us your email address, we can put you on a list so you'll get a reminder for this call every week, if you'd like that.
Okay. Okay. You ready?
I'm ready.
ROCK, Rock Tech, ROCK,
ROCK
TECT
TECT
at sbcglobal.net.
SBC Global. Okay, so let me repeat that back to you. ROCK TECT at sbcglobal.net.
That's correct.
Okay, well, you'll start getting reminders from us that will let you know that there's a meeting coming up, and we usually put some other newsworthy items or anecdotes or something else in there too. So they come from info@ancan.org. So make sure that those don't go into your spam folder. And we'll look forward to talking to you and Robin again. Do you have any questions for us before we move on?
Not really. No.
Okay.
Joe, I just wanted to interject. Last week, I was Elena. This is Steve. Last week I was Elena, but I
Oh,
finally got
okay.
my name in there, so don't feel bad.
All right, I get it. Oh, I get you said. Sure.
Okay.
Robin, one other question I have for you, this is Peter. How are they monitoring the progress? Just through scans, or is there any way they can read the results of these weekly injections to find out what's going on?
I'm going to get a bone scan done, and a CT scan.
Okay.
That's the way they do it.
Okay.
I have a question for Joe. Do you continue taking Lupron once a month?
Yes,
Jake?
I do. Every like 3 months, something like that.
Okay. And
And
are
I
you
take,
are you doing any kind of bone strengthening?
I'm getting Xgeva,
Okay,
right?
good.
I also have a question for Joe, if I
Yes,
can.
please.
Why did you move from MD Anderson to LA?
UCSF.
UCSF, I'm sorry.
We went to MD Anderson to just get information. We were able to do the chemotherapy locally.
Got it.
And then once that was done, they didn't have anything else for us to do with them. So we went to UCSF because we had heard they had a clinical trial.
Got it.
It sounds like your wife is very much on the ball, just like Barbara Discant, and that she's digging around and talking to a lot of people. So I'm impressed. And Sylvester, how does it feel to have somebody else from Monterey on the call?
Who's from Monterey?
Well, Sylvester's kind of from Monterey, right?
I have a sister that lives in Seaside, but she's now in Pacifica, and that's just at the Monterey border. And I used to work in that area, so it's good
Okay.
seeing this gentleman on the call today.
Yeah, that's great. We're neighbors.
Yeah.
Yes.
Yeah, I think Sylvester goes back a long way, many, many years in Monterey. Didn't you used to live in Monterey at one time?
No, I went down there practically each week when I was working, and I would stay in Monterey
Oh, they were
for
trying
the
to see
entire
you.
week and come back
They want to see you.
to San Francisco.
Okay.
There's Robin.
Hello.
There's Robin.
Robin,
Okay.
Robin, we want you to participate one of these days so that we can get a better feel. You've been doing some fantastic work for your husband. We can see that.
Can you hear it?
And we welcome caregivers. We have Barbara on the call right now who advocates for her husband. We know a couple of your docs very, very well, both Larry and Paul Korn. So
Yeah.
when you go to see Larry next week, just tell him that you spoke with AnCan and Rick Davis. Larry is on our advisory board, and he is
Wonderful.
yeah, he's terrific. And so we've sort of got a picture, but we figured out when Joe was not coming up with a few answers that he must have a wife that does a lot of advocating for him.
Okay.
Yeah, right.
So what do you need to know?
No, they got it. They
Oh,
got it.
okay.
I
So
think
the thing at MD Anderson that Dr. Korn subscribed was a duo chemo, which you probably know about, where you do one chemo and then you wait a half hour and then you do another hour of another chemo. And I don't remember what the cocktail was, but it didn't work.
we were wondering.
But that was Dr. Korn's suggestion, that they were.
Taxable or something like that.
He said they were about to publish a paper about it, and they were having pretty good success at MD Anderson with it.
Yeah, it could have been. It could have been carboplatin and cabazitaxel and carboplatin, because Paul did write a paper on using carboplatin. I don't know. The person who would know is one of our guys who isn't on today, who's another Paul Korn patient, who's actually going through chemo right now. But yeah, thank you anyway. We'll maybe you can tell us next time
Okay.
when you come back on, because we would like to know.
Yeah,
But
I have the information. I could tell you.
yeah, okay.
I'll give it to you for next time.
Yeah,
I'm gonna leave you guys.
Okay, bye.
Bye.
Thank you, Robin.
She's leaving.
Okay. All right. Well, thank you, Joe, and hopefully we'll see you. We meet every week, so as many times as you can join us, we'd love to see you.
Okay, sure.
And stick with us, because you may pick some other information up from some of the other guys. So let's move right along to Joe Merger. Joe, are you still with us, I hope?
Yes.
Okay, good. So you wrote to me and you mentioned that
Going to Karen's?
you
Can I go
are,
walking with her? Okay.
let's just mute let's mute Joe. Can you, Jay, could you oh, we're in good shape, thank you. So Joe, Joe Merger, you mentioned that you are also on monotherapy Casedex, is that right?
That's correct.
So maybe you'd like to share with the guys a little bit about this this monotherapy Casedex, which some of you may recall we spoke about last week with I forget his name.
It's Richard Stanton.
Thank you, Richard Stanton. Thank you very much. Okay. Why don't you talk to us?
Well, I went 17 years without treatment, and I've been on this bicalutamide for about a year, and it works well, but I picked it because of minimal side effects, but even that at times has been overwhelming, and I've had to take a vacation from it.
Mm-hmm. Tell us a little bit about, you say that you just started it, so, but you were diagnosed 17 years ago?
Yeah, 2002.
Okay. And so have you been doing active surveillance since then, and how advanced is your disease right now?
No, it's advanced everywhere. It wasn't at first, but I let it get a little out of hand. And when my PSA got to 900, I thought I'd do something.
So your PSA is now, well, what is your PSA right now?
Oh, I don't remember it. I think the last one was like 59.
Okay. And the only drug that you're on is Casedex?
Right.
Okay.
And that 59 was after a 2-month vacation.
Okay. And you say that you only started the Casedex about a year ago?
Yep.
Wow. Okay. Do you have any pain anywhere?
I've had some hip pain, but I've had that for years.
Okay. So
that's about it.
Okay. And what do you see a doctor in Syracuse or?
Yeah, in a hematology oncology practice.
Okay. All right. Well, do you have any questions for us before I throw it open to the guys to talk to you?
Nope,
Okay.
I'm ready for whatever you got.
Oh, well, I don't know that we have anything. I mean, let me go to Peter. Let me go to Peter first. It looks like he's eager to say something.
Well, I guess when you were diagnosed, what did you have a biopsy? What was your Gleason score?
Well, the first biopsy was 8. The second one, a couple of weeks later, was 7. I went to half a dozen different doctors. The urologists want to operate. The radiation oncologist wanted to fry me. Went to a cryotherapy doctor. I didn't go for cryo. I went to get a color Doppler, which was helpful. But he wanted to talk me into cryotherapy before I left. And so it's kind of like buying a car. You go to a Ford dealer, they're not gonna sell you Chevy. I did go to one doctor that was very honest. He was I went to him for a seed mapping, and he said he could do it, but I wasn't the best candidate. So he's the only one that didn't try to sell me on his own treatment.
It's very good. I mean, it sounds like you kind of straddled a high intermediate disease and made it for 17 years. That's impressive. I'm delighted with that. Yeah, I salute you for being your own advocate and guiding your own way. I really don't know whether taking treatment earlier on would have really led you to any better results that you have now. So good for you.
Thank you.
Joe, this is Jake. Welcome to the call, first of all. Second of all, you said your PSA is down to 59 after a 2-month vacation?
Yeah, that was a couple of months ago.
Okay.
Yeah.
So what was it right before you took the vacation? How low did it go from 900?
Oh, I think it was 29.
Okay, so that's the lowest it's been? And presumably it'll go lower after you stay on the case index for a while. Presumably it'll get lower than that.
Yeah.
Good. Okay. Thank you.
You mentioned that you're having a little difficulty with the case index. Are you doing anything? Are you doing any exercise, for example? Has anybody talked to you about exercise to help you?
I know I should, but nobody's mentioned a word.
Okay.
I already know that, but it would help to have some reinforcement.
Get ready. That's Rex bailiwick.
Well, it depends how bad this case index is hurting you. If it's hurting you real bad, then we can tell you exercise will make a difference. There's a lot of guys on this call who will testify to that. If it isn't hurting you bad enough, then you don't need to exercise. But we would strongly recommend, because even though you have testosterone in your body, you're not taking a drug that removes the testosterone. The testosterone cannot get to the places it needs to get to. And that's why you're probably feeling some mental effects. And and one way to do that is to get your heart rate up for about 10, 15 minutes every day, provided that you are healthy enough to do that. How old are you, Joe?
67.
Okay. So I know that at some point a long time ago, you must have written to us to ask us to get you into the MAN plan, which is an exercise program. I don't know if you followed up with that or not, but we would definitely recommend that you do some sort of daily exercise because it's going to make you feel way better. Can I throw this out to anybody else to give Joe some encouragement for exercise?
We'll all speak at once.
That's right.
I belong to, or have until COVID-19, to a cancer wellness program at a local medical center, and it was monitored by a personal trainer, and it was also monitored by doctors for those of us that are being treated, and it wasn't overly difficult. They are very careful not to injure us in any way by putting on too much weight, but they monitor our progress, and I miss it now because I haven't been back to it in a while. So I actually find myself a bit weaker now in this environment.
Thanks, Carl. Anyone else who can testify to the benefits of exercise when you go on hormone therapy?
Sure, I'll go, Rick. It's David. It's made a world of difference for me, Joe. Made a world difference for me. Have you done any sort of exercise before? Have you been exercising? Have you done anything like that?
I had previously, and up until a year and a half ago, I was walking every day, but
So would suggest you get back walking, like Rick says, 10 or 15 minutes at a little higher speed, just to get your heart rate up a little bit, would be a beautiful thing on a spring, June day like this. It'll really help it'll help you a lot. It's like the best drug in the world. Just walk.
Joe, do
Thank
you have access to a swimming pool?
not right now.
Yeah.
When the health clubs open back up.
If you can get access to a pool, that's a good way to motivate yourself to get active when you haven't been active for a while. Especially if you can get in a pool and use swim weights, the floating weights, or a lot of I guess they're foam weights, and you put those under the water, and while you're swimming or moving in the water and using those weights, you're getting the benefit of weight training, but not like weight training in a gym. It's a different feel, but you're still exercising your muscles, and swimming laps will raise your heart rate too. So if you can find a way to get access to a pool, I find it's very beneficial for if you're not used to a routine exercise. So do that. It will help you get to the next step where you're really being a lot more active. But being in the pool is just great, and it's a good gateway to get beyond to another level.
Yeah. So, Joe, we hope you'll keep coming back. We hope we can support you. There's a lot more that we would like to talk to you about, but let's first of all see how you do in terms of resuming your Casedex, and let's see if exercise makes any difference, and then we can start working with you step by step to see how we can get this PSA even lower than 29 that may be possible. But you need to to be motivated to do that, to stick around for a good few years yet, and we can probably help you do it. But I think the first thing is to probably get some exercise so that you get yourself more balanced, because we can hear how this Casodex is getting to you. And so we think that the exercise will make an enormous amount of difference there. So we meet every week. We hope to see your face again. You're on the list. Make sure you whitelisted us so that you see it, and we'll see you. It's a little confusing, as Steve Van Ada will tell you. It's Mondays one week and Tuesdays the next, and you have to get the time right because it changes. But once you got the program down, this is a good place. Anyone else want to say anything, Joe, before we move on?
I have another question, Breakers, Peter. Yeah, you're intriguing because you've been doing this for 18 years, Joe, and the science of prostate cancer has changed so much, and particularly in the last 5 or 6 years. And I'm just curious, because you were one of these rare guys that was diagnosed in his late 40s, if I calculated right, which not many guys are. Have you ever done any germline genetic testing or looking into your genetic profile to see if there's anything driving this disease that is unusual?
Well, 2 weeks ago, my doctor asked me if I wanted to be tested, and they're thinking about giving me Rubraca, but I don't know. I don't think that I qualify. I haven't had chemo and I'm not castrate resistant. So I really don't know what they're thinking, but they don't say too much. And
there's two tests. One's very simple. One just is a mouth swab. It's like a COVID-19 type of thing, but you just spit into a tube, and that just looks to see if you have any genetic mutations or genetically passed down from one of both parents, and that can be very revealing. It was for me. The other one's a little more involved in it, and that involves tissue. And since your biopsy was like 18 years ago, it might not be valid anymore. But that's a different kind of test. But you might want to do the germline test anyway. Start with it because it's very inexpensive, very non-invasive, and it might give you some valuable information. Because being diagnosed in your late 40s is kind of highly unusual. And, a lot of guys get that diagnosis at that age. Often, there's no formula for it, but they often do have some kind of trigger that's going off. So I just mentioned that it's worth pursuing.
okay, thank you.
So Joe, let me just follow up on that. Have you actually done the test yet?
They drew blood for it, and supposedly the company called Myriad,
Yes.
MYRIAD, is going to contact me and tell me how much it's going to cost. If I say no, they throw the sample away. If I say yes, they run the test.
Okay, so it's a little more complicated than that, and I don't think your doctors are really explaining to you, and certainly not what Peter has in mind. First of all, Rubraca is a drug that's available, but since Rubraca was approved, about 2 days later, another drug was approved in the same category called olaparib or Lynparza. That's a drug that Carl Foreman is currently taking. And you don't need to have done chemo to get the olaparib. You do need to have done chemo to get the rucaparib or the Rubraca. So you could be eligible for a drug in that category. The question really is, what makes them think you're eligible? Do you have any family members that had any type of cancer?
Yeah, they took a a quick history before they had me go for the blood draw.
Okay. And did parents or brothers or aunts, uncles who had cancer?
Mother, uncle, both grandmothers.
Okay. So I see where they're going. Now, here's the thing. The Myriad test, first of all, it should be covered by Medicare. Are you on Medicare yet or not?
Yes.
Okay. So it should be covered by Medicare, but what they're doing is they're giving you a more advanced test. There's a more basic test that you can do. That basic test you can do at your cost for about $250 at your cost, and it may even be covered. So if Myriad comes back to you and gives you a big number, talk to us, because there's a couple of ways that we may be able to help you. There's somebody else, there's another company we know that we work with that may be able to work with your blood, or you can do this spit test that Peter was talking about, which you can order yourself for about $250, and that may show that you're eligible for a drug like olaparib, like Lynparza, or a drug like Rubraca. And I think that what your docs have done is sort of plunged you in for a more expensive test, and we don't want that to throw you off, because we can go in 2 stages. We can go to this test, this spit test first, and then if that doesn't work, then we have to talk about the Myriad test or a blood test. Okay?
Okay.
Keep coming back to us, keep talking to us. We can help navigate you through this, and hopefully, maybe you will be a good candidate for olaparib. And don't give up on the Rubraca either, because it may be that your insurance company would approve. If they approve the olaparib, they might approve the Rubraca as well. We don't really know whether one is better than the other at this point. Okay? But we'll help you.
Okay, thank you very much.
And just a quick question for Robin, for Joe. Joe Robin, turn your sound on for a second for us. There you go. What was your? We never asked you. What was your Gleason?
I don't know that number. I can't tell you.
Okay.
I don't know.
All right. We'll have to ask Robin what your Gleason was when we talk to her next. Okay.
Yeah. Right. There you go.
Thank you. All right. Let me run down this roll call here and see who would like some time today, and then we'll get around everybody. Try and cover you all. We've got a little over an hour. Gary Pelfrey.
Yeah, I would like just a few seconds to update you.
Okay. Jake, anything for you?
No, not for me, Rick. I'll have something later on this month when I see my oncologist.
Okay. Russ, anything for you, sir?
10 seconds just to make a statement.
10 seconds to make a statement. Okay. Is this a political statement or not?
No, it's my status. It's just 10 seconds.
Okay, 10 seconds. I'm going to be counting. I'm going to be counting there, Smith. Okay.
I'll make it.
Okay. Sylvester, anything for you? Okay. Thank you.
No, thank you.
Peter, anything you'd like to talk about?
Yes, I have something.
Okay. Joel Blanchette with his video on. Hello, Joe Blanchette. It's very nice to see you. I think you said something, but we didn't catch it. Would you like any time today? We're not hearing you, but it shows your microphone is on. I wonder why. Well, we can see your lips moving, and it shows your microphone is on. Now we lost your. No, I'll come back to you. I'll come back to you at the end. See if you can figure out why we've got no sound from you. Your microphone isn't picking up. Les Shelderup, anything for you?
Not today, thank you.
Oh, thank you. Paul Frieda, anything for you?
Real quick question, that's all.
Okay. Scott, I know you have an update for us.
Yes, sir. 30 seconds. Thank you.
Well, I don't think it's 30 seconds. You guys have a very interesting perspective on time on this call.
Okay, 1 minute.
All right, 1 minute, okay. David Muslin, how about you?
I have a quick question. Won't take more than 30 seconds.
Okay. Steve, anything for you? Steve, what is the right way to pronounce your last name?
Vanada.
Vanata.
Yeah, and I got maybe a 90-second to 2 minute.
Okay, 90 seconds to 2 minutes. Rich Jackson, how about you?
Right now, quiet on the Eastern Front.
Quiet on the Eastern Front. Are you sorting out those trials? Did you make any progress with the trials that I sent to you?
Yes.
Well, maybe you'd like to just tell us about that, because we like to hear about these things when we send you links to trials, you know. And so if we've got time, I'm going to ask you to tell us what you found out from those trials we sent to you, okay?
You know, Rich says things are quiet on the Eastern Front. He must not be watching the news. It sure ain't quiet.
Barbara, are you back with us? I see you. I know you dropped off. Are you back? No. Okay. Carl Foreman, anything for you today?
Not today, thanks.
Okay, we've been getting plenty of action on those PARP inhibitors, Carl.
I like that, yes.
Okay. And Dennis, anything for you?
Yeah, Rick, give me a little bit of time. I talk about a clinical trial. The results are supposed to be out this month.
Okay, so all right. So I know that if Barbara comes back, she definitely has. Or maybe this is Barbara. Is that you?
Yes, I drive through a dead zone on my way home. So the phone dropped out, and now I'm driving through a live zone home in 20 minutes. But well, I don't want to miss you guys.
Okay, so maybe we should just start off with you then.
Someone just joined on the telephone. Is that you, Barbara?
Hey,
yes.
how about starting in with Larry Fish? Remember me?
Yeah.
I did it. Hold on, Barbara. I did it again. I did it again. I skipped right over Larry Fish. Mr. Fish, if you have something you want to say, we're putting you right in after Barbara.
Hold on, I just need 3 seconds. 2 seconds. 1 second. I'm done. I'm done. Nothing else.
Time's up.
Yeah.
I think I'm next, Barry, so I'm going to pull over, okay?
So
I have to take notes.
So sorry. Larry, do you need any time, seriously?
No, Rick, I'm good. Thank you.
I'm so sorry. I do apologize. All right, Barbara, let us start with you. First of all, how did Barry's chemo go today?
Well, he had it. We were worried they were going to delay again. It was delayed last week due to a high AST, which was a liver level. His Neulasta seems to have taken care of any kind of drop in neutrophils or anything like that. He has plenty of that. So his liver functions were a little disturbing. So they delayed it for 4 days to retest. And I was almost surprised they redid his chemo today because they did go down. We made a campaign to have him drink, and it actually helped. Right. It didn't go all the way down, though. Unfortunately, since I'm on the road, I don't have the exact numbers. The problem is with the AST and the alkaline phosphatase. But at least they're moving in the right direction. So he had his second treatment of carbazitaxel. And since the docetaxel and Xtandi failed, we're waiting with bated breath to see how he does. The PSA test came back late in the day, so it hasn't posted yet. It went down, and then in 1 week it went down, and then the third week it crept up again. The doctor doesn't think it's significant. I'm on hold. I'm on a wait and see, and I'll know his PSA tomorrow. I do know also that it takes a few treatments of chemo to really know whether it's going down or whether it's just a bounce. So we're sitting tight, but also wanting to plan the next move for whenever it comes, whether it's next month or next year. And so, we got the Foundation One back.
So, slow down. Okay. Let's talk about this PSA. What was the PSA? The last PSA I have was 4.5.
That was his nadir. That was 6 months ago.
And so what is his PSA before he started the cabazitaxel?
It was somewhere in the 50s.
Okay. And what was it after the first one? I mean, or just give me the last couple of weeks then.
It went down to 30.
Okay.
And then it went up to 35, and now we're waiting to see. He did weekly tests for the first cycle, and then he'll be doing every 3 weeks. So we had a 30, we had a 35, and now we will see tomorrow whether it's gone up or stayed stable. We don't know.
Okay. So there are, and we're going to talk about the Foundation Medicine right now, but there are guys on this call who have done chemo and who have experienced changes like you're looking at in their PSA. And, you know, when it moves from 30 to 35, that really isn't, even though it sounds like it's significant, it isn't that significant. And it does take time for these drugs to kick in. And then the other issue, of course, is that with a lot of these drugs, they have a flare effect, meaning that
I'm aware of.
Okay, so, you know.
Yeah, I guess I'm gun shy because this is what happened with docetaxel, and then it turned out not to be a flare effect. His PSA just skyrocketed and his scan showed progression, which is why they took him off docetaxel. So I feel like I'm a little gun shy, but we're trying it.
Okay, so you got your, why don't you tell the guys what the Foundation Medicine report turned up? And for those of you who don't know what the Foundation Medicine report is, Foundation Medicine tests your tumor and it looks for genetic mutations that your body has created, as opposed to mutations that you might have inherited from your parents. And they can do that from a solid sample, a solid tumor sample, either bone or soft tissue, or they can do it using blood, but the solid tumor sample is usually more reliable. They will analyze it. It usually takes them plus or minus 2 weeks, and then they send you a report, and which is what Barry just did.
Yes.
So why don't you tell us what the report showed, Barbara?
Well, we're still incomplete because I was supposed to get it today and it turned out they're mailing it to me. So there may be more than I'm telling you now. He,
Okay.
by the way, had both a solid and a liquid because his last solid failed. So they decided to do both in the chance that, you know, they redid the solid and they did a liquid with it.
Okay.
So far, what we have is an ROS1 mutation, which is supposed to be rare. And his doctor suggested I'm sorry, I don't have it with me, entrectinib as a possible later medicine, which is pan-cancer, meaning they actually approve that for the genetic modification rather than the kind of cancer.
Correct.
So and that's what they talked about, but I still would love some more clarity on all of this.
Okay, so I don't know much about the medicine. I think let me just give me a second here. Let me just pull up, which I think the one you're talking about is I think it's the Roche. I think it's the Roche drug. Oh no, that's
another one. Last something.
Prostate-Specific. Yeah, there are. Let me step back one. For the guys on the call, ROS1 is a fairly rare mutation in prostate cancer. Shows up in about 1.5% of men. Having said that, it shows up in a lot of different cancers, which is why this is a pan-cancer approval that these drugs have. It's a tyrosine kinase driven mutation, which is a word I've been hearing for years and years because I used to attend these retreats at UCSF. I don't know much about tyrosine kinase other than the guy who does the research and never really understood it. But they have something called a tyrosine kinase inhibitor, which is what these drugs are. And they are suitable for certain mutations like ROS1 and ALK+. There are trials going on and there are approvals. Now, I have sent you, Barbara, a list of all the meds that I found out today are used for ROS1. I don't know if you've seen that yet, but I emailed that to you with some explanation on there. I also wrote to our advisory board member, Ellie Van Allen, who runs the Metastatic Prostate Cancer Project. Have you, has Barry signed up yet for the Metastatic Prostate Cancer Project?
This is the first I've heard of it.
Okay, so I'll send you the link and you have to promise me that you'll sign Barry up. All he's got to do is spit in a tube.
I will promise that I will do that.
Okay, so the Metastatic Prostate Cancer Project, for everybody who is listening, and many of the guys are already signed up for this, is a patient participatory program that is trying to map all the genetic alterations in prostate cancer. And they do that by asking men to send them their genetic information. They spit in a tube, and then they also provide their access to their medical records. And the project is run out of the Broad Institute, which is affiliated with Harvard and MIT.
Okay.
And if you look on our website and you search for MPCP, you will find a presentation, a webinar from the guy that leads the project, whose name is Ellie Van Allen. And so I wrote to Ellie and said, Ellie, what do you know about ROS1? Do you know any docs or any GU medoncs that are researching? And he said he didn't, but here's what he offered to do. He didn't make the exchange, but I'm asking for the exchange that you join the project, is that once we get your FMI report, he's happy to look it over for you, which is a fantastic offer because he's one of the best prostate cancer geneticists in the country. And
I am honored.
And so it's very kind of him to, and what they have the ability to do is to see if anybody else with a similar mutation has responded to a particular drug. And if they can't give personal information, they don't give any of you personal information, but if there's a treatment that seems to might have worked for another ROS1 person, he'll let us know what that treatment was. Okay? So
that means a lot. Thank you.
Okay, now don't hold your breath because right now they don't have it there. I think who can tell me how many people are enlisted in NPCP from their latest news? They send out a quarterly newsletter. David, how many people are now enrolled in NPCP? You're muted right now, David.
You know, I can't answer that question, but I went ahead and did the test and so forth.
Okay. Does anybody remember? I need Len. I know Len knows. Peter, do you remember how many people they have? About, it's less than 1,000, but it's more than 500. You're muted, Peter.
It's not a huge number yet. It's, yes, something, you're right, it's between 500 and 1,000. I'm thinking it's more like 600-700.
Yeah.
So they can always use more.
But Barbara, you'll be, I know, I already have a feel how your mind works. You'll be fascinated with this project, and they are fabulous people. Their heart is so in the right place. And as you can see, you know, Ellie offered, he said, you know, if they would like, I'm very happy to review the report. And, you know, we're delighted because since we lost Professor Bill, we haven't had anybody to look at these FMI reports for us. And this is the second time recently that Ellie's offered to review a report. And so I think if we carefully use Ellie as a resource, he'll be there for us when we need him. But what I really want to tell you is, yes, there are tyrosine kinase inhibitors. And maybe they'll work, maybe they won't work. We just don't know enough. It's a little like what we're going through with PARP right now. So, so that's really where we are. So when you get that report, you'll get it in digital form. Send it on to me.
Rick,
I will certainly.
This is Steve. I signed up about 2 weeks ago. You know, after you mentioned that, and I watched the webinar or video, and I did go online to their site and submit all the information, but I have not heard from them yet to submit a test kit. So I'm still waiting on that.
I don't know what the lag is right now. I do know that they're all working from home. I asked Ellie today, and because his is a wet lab, they're not up and running. So what I can certainly do is find out what the lag is and let you know. David, how long did it take for you to get your packet between the time you signed up and the time you got the packet?
I think maybe 2 to 3 weeks.
Yeah.
Guessing it's been a few months.
Me too, Rick, and that was in good times.
Okay.
Yeah, that was definitely, it was right as COVID was starting.
Okay. So, Steve,
everything is thrown down to a crawl now. Even priority now takes almost 2 weeks to get someplace. So
Right.
it's kind of easy now.
So Steve, do me a favor. If you don't get it in another couple of weeks, please let me know, and then I'll follow up for you. Give it another couple of weeks.
Okay, we'll do.
Okay. And I just saw Jim Ward leave, and I think I forgot to ask Jim Ward if he wanted any time today. So Larry, don't feel so bad. I blew Jim Ward off altogether. I have to send Jim a note afterwards. Okay. We're going to keep moving along here, Barbara, but we're on it. That's the best I can say to you.
Well, I thank you. That's all I can say to you.
Thank you. Okay. Jerry Pelfrey, what's on your mind?
Well, first of all, I'm going to go to Phoenix to see Dr. Singh next week. We've got a set up for Dr. Singh and then Dr. Shield, my RO. It's a 6-month review. And locally, I've been going to my lab here and checking it out because, you know, Mayo doesn't go below 0.1. They say 0.1 and that's it. Found out that my PSA now is 0.05. So I'm pleased with that, and we'll see what Dr. Singh says on Wednesday. Mm-hmm. But my question is, on what I'm on, Lupron, Zytiga, and I've changed from Zometa to Xgeva, and now I have some left hip pain, and I've got a left TMJ joint that is giving me some pain. And I was wondering if either one of those are potential side effects from what I'm taking.
When you say from what you're taking, from let's see, you're on Zytiga and Lupron. You know, probably not from the Zytiga. People complain about joint pain from Lupron, but it's very general. I mean, I would have to say it's more likely, although you don't want to hear this, that it's probably pain from the cancer.
Yeah, well, that's what I was thinking, but I just wanted to ask.
Okay, but here's something that I really would encourage you to do when you're at Mayo this time. Because if you are having any sort of pain issues, it's time that you place a palliative care doc on your team. And, you know, the palliative care docs are not end-of-life docs.
Right, right, I understand.
They
are. As a matter of fact, my wife mentioned that already, that we should, and that, I don't know, I'll have to ask Dr. Singh, is there a palliative care doctor at Mayo?
There is, because I have looked, and they have a whole palliative care group at Mayo, and you have to insist. You may get no resistance from Dr. Singh, and you may get resistance from Dr. Singh. So let me explain the dynamics, important for just everybody here. First of all, let me say we have a bias on this call. We believe that palliative care docs play a very important role in the treatment of metastatic cancer. Palliative care docs treat symptoms. In some hospitals, they even call themselves the symptom management group rather than the palliative care group. And what they're there for is to help you with any symptoms you have. If it is something in your jaw, if it's something in your hip, if you're feeling nauseous, if you're feeling fatigued, if you're feeling liverish, they are there. Now, a lot of times your oncologist wants to treat that themselves, but they don't have the knowledge. What they know about is cancer. They're not experts in pain meds.
Right.
Some of them think they are, and some of them are resentful. Some of the very best ones are resentful about having a palliative care doc involved. You've heard us say 1,000,000 times, you are your best advocate, and you have to advocate to add a palliative care doc to your team.
Okay.
All
Well,
right?
Singh has been pretty good about that because he set me up with a neurologist at one point and also set me up with the nutritionist at Mayo. So
Good.
I anticipate that he will set me up with a palliative care.
What I would recommend is go to the Mayo site, look at the palliative care docs in Mayo, Arizona, and see who you like. And that way you can ask you can ask for the doc that you like rather than being assigned to a doc.
Okay, that's a good idea.
Okay, and
Yep.
And I think I can't remember. It's possible that your wife has Debbie has some information on that. I can't remember, but you can easily find it and then decide who you like. Okay.
Yeah, not a problem. That's all I've got. I'll tell you more when I get back.
Jerry, this is Dennis. Dr. Singh is very much in favor of that. Matter of fact, when he was down here at the U of A Cancer Center, he led me to a very good palliative care doc down there that I used for quite a while. So
Are you still using them?
I don't use the one down here because I don't go to the U of A anymore. So it was a woman, but she was pretty good. I guess she called herself a supportive care, not alternative care or anything like that, but it was supportive care, mostly like Rick says, for the things, the side effects and so forth that people get going through chemo, whatever. She was good. The other thing is when Singh left here, and I inherited another doctor down at U of A, and I told him about some pain in my left hip. And he says, "Oh, that's your cancer." So I said, "Oh, no," and that's about shortly after that, I left him and reassigned myself to Dr. Singh up at Mayo. And I talked to him. He pulled up my bone scans, and he could tell, that's osteoarthritis. That's not your cancer. That's osteoarthritis. So
yeah.
if he's got your scans, he could probably tell you right away what it is. If you tell where the pain is and the two go together, you could have that.
Well, that's a good idea, and he does have all my radiographs. So
same story I went through with him. So I'd share that with you.
Yeah, thank you.
Thank you, Dennis. Since you've got the floor, keep it and tell us what you wanted to speak about.
Yeah, I just thought I was doing my research on neuroendocrine prostate cancer, particularly the therapy-induced neuroendocrine prostate cancer. This is where our adenocarcinomas morph into a neuroendocrine.
Yes.
And you could do this, you could have neuroendocrine for a number of different reasons, but this one is specifically related to ADT and abiraterone. The study, among many things, said that 30% of castrate-resistant prostate cancer patients receiving ADT, such as Lupron and abiraterone, developed this therapy-induced neuroendocrine prostate cancer. So the trial, and this is that type of cancer, as many of you know, has very limited therapeutic responses. So this trial, it's called PRINT, but what it is, it's what they call a rapid drug cycling, where they put you through cycles of different drugs. So if you look for the clinical trial PRINT, I could give you the number, but this is really to determine if there's a potential to delay the onset of this treatment-induced neuroendocrine prostate cancer. It gets pretty technical. It's probably beyond my capability to understand it all. But some of the stuff that I get out of this, they're going to have different groups, and then there's different modules and different combinations of drugs. And I think they switch you off every 12 weeks. And there's an abiraterone, enzalutamide, and a radium-223 combination for one group. There's a carbazitaxel carboplatin combo for another group. But the big thing is the study's completion date is June 2020. So I think it's, whether or not we get the actual results of the study within June, is another question. But it was started back in January of 2017.
Yeah.
So it may not help, it may not help us, because the people they put in the trial looked at they couldn't have any chemo, or there was, basically just started and they get a high Gleason score like a 9. And so then they can use these types of treatment to prevent them eventually having to deal with this neuroendocrine cancer.
Right. So a couple of things. If you would be kind enough to put the trial number in the chat window, that would help us all when we're done speaking. Secondly, I think this may be a follow-up with for the discussion that we had the other day, that last meeting or the meeting before, that we have seen men who have done very well on second-line antiandrogens finish up with a neuroendocrine form when they eventually failed, which we couldn't find a way to treat. And I think I mentioned to you, Dennis, it's something to talk about with Dr. Singh, that maybe you do need to change up your abiraterone treatment. I will tell you that I asked Dr. Rathkopf about this in light of Richard Foodie, God rest his soul, and asked her, does she think there's any value to changing up treatment when a man is doing very well on a drug Richard got 4.5 or 5 years out of Xtandi? She said no. I don't know, but I think it's a very valid question for anybody that's been on a second-line antiandrogen for a long time. I'd also say about the trial, it's probably been extended because of COVID, and that these trials take quite a while to report anyway. But I definitely think it's something you should review with Dr. Singh next time, particularly given your success, your terrific success with abiraterone. Okay, thank you for bringing that to our attention. We love you guys. We love you guys. As I said at the beginning, this is an amazing brains trust that we have here. Fantastic. Okay. Scott, sorry, did anybody want to ask Dennis a question about that, about this PRINT trial?
May I ask Dennis one question, please?
Yes.
Dennis, is this, and I tried to follow you, is this saying that they want to switch up after a certain period of time, like the abiraterone, they would want to switch up to something else?
That's correct.
And what would be the basis of that?
The theory is similar to what that exist with certain types of bacterial infections, such as, you get these, end up with these superbugs because they are so exposed to one type of antibiotic for so long. And then, so it's kind of based on that theory.
Yeah.
But don't ask me anything more technical than that about it.
Okay. Thank
Did
you.
you, anybody see that, what I put in the chat room? Did it show up? Put the number in there.
I see it, Dennis. It's in there.
Yeah.
Okay.
Yeah, thank you. Thank you. Okay. So
I just wanted to make a comment about clinical trials specifically, which I am included in one. And I spoke to the head of my clinical trial just last week and asked him the status of what was going on. And he said pretty much across the country, they were not recruiting anyone new for any of the clinical trials at this point because of the COVID-19.
Yeah, we've heard that too.
Right.
This one is so close, and whether or not they, it's been running for so long, for several years, and it's supposed to be completed this month, so maybe they got it done.
Right. I think that Dennis is commenting on this trial, not so much from wanting to enter it, but he's very anxious to see the results, and he wants to bring it up to his medical oncologist because it might apply to his case. Where Dennis, how long have you been on Zytiga? 2 years now? 3 years?
No, since 16, I believe.
Yeah.
2016.
Yeah. Okay, Scott, give the guys an update on what you're planning.
Well, first, this is a big shout out to Rick. I went and saw a radiologist Friday. She suggested treating several Mets. I have 5 Mets. I thought this is the answer. Rick is just amazing. I don't want to be crazy, but anyway, I called him. Should I do this? I emailed this morning. I ended up interviewing Dr. Shukla. And then finally, I got a hold of Dr. Vargas. I decided not to do the radiation. And I really needed him to explain, to go deeper. And several of the questions I asked were generated from Rick's thing. Rick, thank you. It really is a big shout out because I was going back and forth in my mind. I mean, I'm honestly trying to do the best I can, but I decided not to, based upon my final discussion with Dr. Vargas. So again, thank you, Rick.
So can I just fill the guys in because I know what you're saying. So Scott has an oligometastatic situation, marginal oligometastatic situation, meaning that he's got 5 observable metastases. Oligometastatic disease is usually treated with spot radiation if there are 3, maybe 4. But on the very top margin is 5, but we've seen that it's not often recommended. The radiation oncologist at Ironwood recommended against spot radiation. The radiation oncologist at Mayo recommended against. Scott went and saw a 3rd radiologist last week, and that radiologist said, yes, I'm willing to radiate. So between yesterday and today, Scott and I have been going back and forth as to whether it makes sense to radiate these 5 spots. Now, the radiation oncologist came back, that this is the latest one, and she said that she was worried about a certain spot that she felt could cause significant harm to the spine. And so I said to Scott, this really falls under palliative radiation and not oligometastatic management of the disease with radiation, because even though you don't have pain now, we're radiating this to stop a symptom happening. We're not radiating to cure it. She insisted that she wanted to radiate 3 out of 5 spots. She wasn't going to touch the other 2, and she called this part of systemic treatment. And I pointed out to Scott that it isn't really systemic treatment because you're leaving 2. Now, it could be that this abscopal effect that we've talked about many times on this call, where the radiation stimulates your immune system, that could qualify it as systemic. But really, I felt that Scott needed to talk about the pros and the cons back with Mayo, and I was also very concerned that if he went forward and did this against the advice of his radiation oncologist at Mayo and his medical oncologist at Mayo, they would not be too pleased. So I guess that Scott's had another conversation with Dr. Vargas, who is the rad onc at Mayo, and his current thinking is not to do this. Is that a fair summary, Scott?
Yes, sir. And again, thank you for your time. I was just very grateful.
A pleasure.
I wish I could give back. I want to others as well. But thank you.
You will. You'll give to others. But this is why we're here. This is what we do. We just don't want you rushing into treatment that may not be the optimal treatment. We can't tell you what the optimal treatment is. You have to come to your own decision. I have one question, which is, does Dr. Vargas think you need to radiate this one spot in your neck that Dr. Whatever her name was, Scholker thought is dangerous?
Good question. When I was talking to him on the phone about 4 o'clock, he pulled up the scan and he looked at it and he said, well, the spot is pretty small. I think we're just going to wait and see. Okay. So he had a different opinion than Dr. Shukla. And frankly, it's kind of like flipping a coin. I just said, okay, we'll just wait this out and see.
Well, I mean, I think, as I said to you the other day, or yesterday, the radonc's going to hope that that spot will be eliminated by the Lupron and the abiraterone that you've just started, and they'll keep their eye on it. And if it isn't, then they'll radiate. But to radiate now, when you've only been on abiraterone and Zytiga for a couple of months, we're not giving it enough time to work. Let me open this up because some of you other guys might have been in situations like this, and I feel for Scott, who's still a deer in the headlights. Can anybody give him some comfort about how to make these decisions?
Scott, where are you being treated? Where do you live?
I was at Ironwood. I don't know if these names mean anything.
Where do you live?
Phoenix.
Surprise, Arizona, Phoenix area.
Okay. I had 2 spots, metastatic lymph nodes a couple of years ago, and one of them was in a very tricky area. And I got advice from UCSF to do radiation with SBRT, but I ended up going down to San Diego to Dr. Carl Rossi and getting proton beam radiation, which is very exacting radiation. They can pinpoint exactly where it goes, and it goes to the tumor and not through the tumor. They use it for pediatric brain tumors because it doesn't do much collateral damage at all. The radiation doesn't go beyond it. It might be worth a consultation going down to California Proton Center in north of San Diego someday if you want to drive down there.
I've got to stop you. Peter, I've got to stop you. This man, look, we're trying to settle this guy down. I don't see, he's had 3 opinions. I'm sorry to be harsh, but here's my reasoning. 5 spots, 5 metastatic spots. The issue isn't about the spot being too near to anything. It can be radiated with SBRT if it's considered dangerous. It's not considered dangerous. This isn't the situation that you had where the SBRT could have been dangerous. And the question really here is, do you radiate a man with 5 spots? You didn't have 5 spots.
Okay. I misunderstood. I thought he was talking about a spot in his neck that they wanted to watch to see if it grew. It was a dangerous spot. That's what I misunderstood. Sorry. I wasn't talking about doing the whole thing. I was just talking about that one area that I thought I misunderstood the comment. I thought he was saying a dangerous place.
That one spot that could finish up in a dangerous place but isn't right now, we can watch and we can determine how to radiate it. The question is, does this man go in for radiation to all of his metastases right now, or at least 3 of them, or does he stick with the abiraterone?
Yeah, probably should stick with the abiraterone. I just, again, I misunderstood. I wasn't suggesting that he do the whole game, but I thought there was a concern about one spot. That's all.
Well, I would say to you, Scott, if you have a concern about that spot, if it needs radiation, we'll talk to you about the best type of radiation to get for it. If there's any danger from the radiation. Right now, they're not talking about danger from the radiation. They're talking about danger from that spot moving in to the spine.
Yes. Thank you.
Anybody else? Okay. Next, let me see. Peter, this is working well. You have the floor. You keep the floor and talk about what's on your mind.
Yeah, I was going to mention this last week, but I didn't get time down, I guess. So, where am I? I'm 10 days away from chemo number 5 out of 6. So I'm past the halfway point. My question is anybody done Procrit injections for anemia, for stimulating red blood cell growth, hemoglobin, hematocrit, red blood cell count? Have you had experience with that? Because anemia is pretty common in chemotherapy or all kinds of treatment over the years for prostate cancer. And that's been my bag for the last 6 years. But now when I'm on chemo, my hemoglobin's dropping down below 9, and in these days of COVID-19, the last thing I want to do is put myself in a situation where I'm going to do blood transfusions, because I remember the days when they thought blood transfusions were safe, and they never screened for HIV, AIDS, and people caught it from blood transfusions. So I just don't trust blood transfusions right now. Not that I'm a candidate right now, but it's heading that way. So anybody ever do Procrit shots? I took my first one last week, and I'll be doing it each time over the next couple of chemos.
How are you feeling? Do you feel like it's given you any energy? Do you feel better from it?
No, I think it's going to take a couple of weeks. I'll do a blood test a week from today, and that'll tell me, it'll give me a reading on when there's effect. I think it takes at least 2 weeks to kick in. And I asked Turner about whether there's any contraindications, because both Neulasta and Procrit work on both through bone marrow. Neulasta stimulates the white blood cell, Procrit stimulates the red blood cells. And I've asked if you can do both at once, and they seem to indicate that there's no problem doing both at once. So I am doing both at once.
Anybody that's done chemo on this call that can talk to getting Procrit or Procrit with Neulasta?
Not very popular. Okay. You have anybody, let me know.
Yeah. My husband is doing Neulasta right now with carbazitaxel, and we've heard of horrendous side effects, but he hasn't gotten them. So we're just thankful. And he has not, his immune system has stayed up where it should be. So as far as we're concerned, he's doing well.
Yeah, I've had Neulasta side effects. They only last for a day or two, a night or two, something like that. And you can usually treat it with.
Right. I mean, Dennis finished up. Didn't you finish up in the hospital with Neulasta side effects?
No, that's why it started me on Neulasta.
Okay.
After I ended up in the hospital.
Okay.
And then they put me on Neulasta.
And you haven't had any side effect issues from them?
No.
No. Okay. Well, I mean,
I'll let you know what's going on. I'll do that blood test next Monday. I'll probably have some results by Tuesday.
Yeah. So we've had guys that have used Procrit, but not very often, Peter. So I don't have a good feel for it. We've had plenty of guys that have gotten blood transfusions, but I'm probably in this environment, Procrit is a better option than blood transfusions. I'm going to keep moving. Steve Vanatta.
Yes, I just to update you on my status. You know, I've had 2 treatments of Ferragamin and Firmagon. I'm sorry, and my PSA has dropped from, and I've never had a high PSA. My highest level was 7.8, and after 2 treatments of Firmagon, it's dropped to 1.5. So I'm wondering about, I'm just a little perplexed about the relationship between this treatment with this hormone therapy, ADT, and how it's dropped my PSA and how much more treatment I need. I mean, if I go maybe 3 or 4 more treatments of Firmagon and my PSA continues to drop down to an acceptable level, do I need the chemotherapy, which is what's scheduled next, is the docetaxel chemotherapy, and then I will be moving on to a clinical trial with Opdivo it's a phase 2 trial, and so that's the drug they're going to put me on in the clinical trial. But I'm kind of trying to figure this all out in terms of, I know the objective is to get your PSA down to a certain level, perhaps below 0.5, and I'm heading in that direction. So I'm kind of like wondering how much other treatment I need and how this works in conjunction with my metastatic cancer and my metastatic diagnosis and the PSA continuing to drop.
So I think what people need to know is that you were diagnosed DeNovo Metastatic, meaning off the bat DeNovo Metastatic, with multiple mets in your spine and your skull and lower rib and lymph nodes. and you're asymptomatic, and
Right.
you were diagnosed with a pretty low PSA. So I'll give you my 2 cents, and then I'll throw it out, which is this. Ideally, you want your PSA to drop below 0.1, not 0.5, but 0.1. And there have been studies done that predict the success of treatment depending on how quickly your PSA falls. And you can find those studies with a little bit of Google research. What was the date of your first Firmagon shot?
It was April 29, and that was the initial 2-shot double dose of I guess 120, 120, and then 120 mega whatever, and
Right.
and then I had another one last Thursday of 80 mg.
Okay, so what we're looking at is your PSA falling from 7.8 to 1.5. When was the 7.8?
Well, I was diagnosed on March, I think March 5th, and then I had a PSA test done about 2 weeks later. I'm going to say around the end of March, and then on the 29th, I had the double shot of Farragon or whatever it's called, and then so when I went in for the second shot, they did my blood work before I had the shot.
Right.
So the second shot. So that drop was based on the first infusion from 7.8.
Let me ask the question again. I know that your PSA was around 3.8 when they did the biopsy.
Yes.
Well,
that was prior to. It was prior.
Right.
That was in October of last year.
When was the PSA at 7.8?
Shortly after, maybe 2 weeks after, a oncologist at a different clinic ordered it for me. I went and got it done, and it came back.
I have to move.
Late March.
It's getting late. So mid-April, you're at 7.8, right?
No, late March.
Late March, you're at 7.8. Okay. So what I'm trying to get at here is from late March until you were at 7.8, you started your Degarelix a month later. Do we know what your PSA was right before you started?
No.
We don't. Okay, so let's assume it was something higher than 7.8. We're not sure what. And it's fallen to 1.5 in about a month. That's pretty good. Now, we want to see where it comes down, but the fact is that the protocols for somebody with high levels of what they call high volume metastasis, which is what you have, is to do LHRH, Degarelix or Lupron, and to do chemotherapy.
Okay.
If you were to do just the LHRH, then the trials have shown that you won't get a lot of success. You'll become castrate resistant pretty quickly, even though we may see continued drop. So I know it's very hard when you feel good, you're managing the disease, and you think, why the hell am I going to do chemotherapy right now? Well, it's because these trials that we've seen over the past 3 or 4 years or 5 years have pointed out to us that the best course of treatment for a man with your type of disease is to follow this with chemotherapy because they've tested it.
Right.
And they see that as being even more successful than giving you Zytiga or enzalutamide or one of the others right now. Who else can, is there anybody else that can add to this, can try and explain to Steve why it makes sense to stick with the program?
It's Steve, it's Dennis Correia again. Very similar to my situation, you know, I'm going through life feeling fine, and all of a sudden a routine annual exam shows my PSA is up to over 4 or something or other. And then you go see your urologist and you get your biopsy, and meantime it, you know, still climbing on 15 something, 18 like crazy. And then you get to see a good GU med-onc, and he realizes with the number of mets, you know, you get the scans and then they see where all these mets are. It's a systemic disease, and you know, you can't go after it piecemeal. And so I started the same way with you with the Firmagon shots, and I had a heck of a time with it. They're very uncomfortable, itching and so forth. So they switched me to Lupron, but that's pretty common. They give you the Firmagon, you don't get any bump in your PSA from a no tumor flare. That's the best way. Then you can switch over to Lupron. It's a lot easier shot, at least it was for me, get it in the butt. But it's a crazy disease because you have no symptoms, and then you start these treatments and you start having these, oh boy, I feel lousy, blah, blah, you know. And then the chemo was the recommendation too, which I started several weeks after I got the shot so they could get me in for the chemo and a dose of Taxol. But that's just as Rick said, that's what worked, and that's worked for me very well. And I went pretty far, like another year maybe before I started to have an increase, and then I had to add, you know, the second line antigen to that cocktail.
Okay. Scott, what did you want to ask something? You're muted, yeah.
Oh, no, thank you.
Okay.
My wife's
That's how you
wondering
raise
how
your
much
hand.
longer I'm going to be on.
No, Rick, I wanted to ask you now. I am scheduled for the docetaxel, but they're going to administer this this clinical trial at the same time, the Opdivo. So I'm still, you know, rolling this around in my head because I know that the docetaxel is not going to be a nice trip, but I'm going to add that on top of it. And so it's just kind of, I'm still up in the air about, you know, how that's going to affect me. But I feel like maybe it might, because I've seen a trial where they used Opdivo and something called Yervoy together, those two. And it helped the patients tremendously, but that's not the case in this trial. I'm in the second phase of a clinical trial, and they want patients who are doing chemo and at the same time that they administer this. So it's kind of a gamble. It's kind of a long shot, but my oncologist says.
Let me jump in because we've still got 3 guys to get to.
Okay.
My biggest concern, based on what we've seen here, is that the Opdivo is a tough drug, and there are markers. I think we've talked about this before, and they need to run the tests to see if you are suitable for Opdivo. They need to know if you have a high tumor burden, if you have high microsatellite instability, if you have any MMRs. I forget what MMR stands for right now. That's why I have Len with me. Peter, do you remember what MMR stands for?
No.
So,
Well, Rick,
but-
they are going to sequence my tumor from my prostate biopsy tissue prior to beginning this. So we'll be, it gets us 4 to 5 weeks away. So that will happen.
and again, there, you know, they really should be sequencing the solid tumors, because the prostate tumor and the solid tumors may not be exactly the same. We know that all your solid tumor metastases are probably identical because they've done that research, but it's not the same as the prostate tumor. And if you've got solid tumor, they should be taking from the solid tumor.
You're talking about bone met tumor?
Bone mets, yeah.
Okay.
Yeah. But my biggest concern, mismatch repair deficiency. Thank you. Larry Fish. So MMR is mismatch repair deficiency.
So Rick, should I insist on that before we begin this trial?
I think you've got to sit down with the doc there, Shahood, and say, look, I've been doing a lot of reading on Opdivo, and Opdivo has significant side effects. I think I sent you, didn't I send you an article on the side effects?
You did.
Yeah. And I want to know if I'm a candidate for Opdivo before I take it. I don't want to take it blind. If I'm not a candidate, I'm not interested.
Okay.
And, you know, do your, if it were me, I would do my chemo, which I think has got to be done. And then at that point, decide what's next. If it turns out that you have the right markers for an anti-PD-1 drug, you can do an anti-PD-1 drug then. But if it were me, I would not be doing an anti-PD-1 immunotherapy at the same time as chemotherapy. Peter, you're doing chemotherapy right now. You've been around.
And I was told not to start the anti-PD-1 drug until after chemo because I wouldn't be able to handle it. So
yeah, I just want to say,
I know it's a trial, but it sounds fishy to me. It's more of an aggressive therapy. It's not. I mean, you're putting your neck out there. It sounds like to me. I'd be pretty cautious.
Yeah, I just want to say that the way they have presented it to me is that that the trial is looking to put a candidate in the trial that they can do the chemo and the trial drug consecutively at the same time. That's the candidate they're looking for.
Right, I hear you, but you preparing, it could be a very wild ride. I mean, it's like putting you on a wild horse or a bull for the first time right out of the chute. I mean, the chemo itself is crazy. I mean, I'm having a hell of a time with it, but I can't imagine doing both at the same time. I don't know if that's just me. I mean, maybe, I don't know whether they really think, I mean, they think this is possibly going to help you, and they think you'll be a great candidate for future medical care.
Yeah. Okay. Thank you.
Again, if you're asking me, if you're asking Peter, for ourselves, we wouldn't consider doing them at the same time because the side effects could be just way too onerous. And, you know, you don't want to be the one that proves that the side effects are onerous.
Believe me, I don't.
And that's why they're courting you, because they figure, you know, this guy, maybe he'll try it for us and then we'll find out.
Yeah.
But you've got to be very careful of clinical trials. You've got to be very careful of the conflict of interest that these docs at these institutions have. And you can ask us. Peter specifically spoke to his GU Med Onc about this.
Yeah.
Now, I remember, and they said, you know, should we do it? Because Peter's a candidate. We know Peter's a candidate because of the mutations he carries. And they said, no, get the chemo done first and then we'll talk.
Well, I think I'll get the tumor sequencing done, and then I'll tell him I'm not interested.
Okay.
And my medical oncologist is a very aggressive guy. I mean, he doesn't shy away from, you know, going for treatments and throwing things at it, but he was very insistent that that was not the way to go for me, doing the double whammy.
All right, I appreciate your time. I know you got to move on. Thank you.
Let me just ask you one question because it's in your interest. Where are they planning on sequencing this? Are they going to do it in-house?
Oh, that I do not know.
So you need to find out, okay? Because you don't want...
Rick, that what they're doing, I guess I should say, what they're doing is they're sequencing, as I said earlier, from my biopsy tissue. They're not doing the bone tumor. Okay. So I'm going to ask them to do that.
Okay, but where are they going to sequence it? Don't let them, how old are you?
I'm 68.
Okay, don't let them use your foundation. Don't let them use your somatic Medicare sequencing to do it. If they want to sequence it, they do it on their butt, not on yours.
Oh, let's see. Okay.
Okay. It's very important. You get, and we're trying to change it, but right now you get a once in a lifetime, one cancer, Medicare approval to sequence your tumor. And it's covered.
I remember you mentioned that earlier a couple of weeks ago.
And don't let them use that up in this trial.
Okay.
You may need it down the road.
Yeah.
Now they may be sequencing in this within their institution, which they can do. In which case it won't be charged back to you.
Well, this is a cancer research center, Moffitt Cancer Research Center.
I know that.
Maybe they are. I don't know.
They have, that's right. So they have the ability, but they may not. And they also have, they may even try to charge Medicare within the trial. So you've got to make sure that if they sequence it, this is outside of Medicare.
Okay. Good advice. Thank you.
Okay. They're dropping like flies. Who have we got left? Let me see. We've got Frida, who says he can wait. We've got, we've lost Russ, who was just going to give us an update. David Muslin. So sorry.
Does it me, Rick?
Russ is back.
Start the clock, 10 seconds. Just want to say, halfway through my radiation on Friday, and today is the 21st day out of 40. So that's it. I beat it.
Oh, wait. Have you exercised this week?
Every day.
Do you feel better for exercising?
Definitely.
Yes. Okay. You tried to wing that past me with the 10-second rule, didn't you? Huh? Okay. Unfortunately, up there, Joe Murch is still with us. Joe, we got this guy to promise that he would exercise every morning this week because he was complaining about his radiation. And he did it. And he tells us he feels better and he looks better. Very important. A trial of N equals 1. And we report success. Okay. Thank you, Russ. Go on, you can say something else. You can turn your microphone on. Go on. You don't want to turn your microphone on? No. Okay, I'm writing it down. Russ Smith exercise. I know what to put on the reminder. Okay, we're delighted. Seriously, I pull your leg, but we're delighted that you feel better. Because you're not supposed to feel better the further you get into the radiation. You're supposed to feel worse.
Yeah,
By the way,
that I got dehydrated because I was drinking so much water before my treatment. I wouldn't drink for the rest of the day, and I learned to fix that by continuing to hydrate all day. So if anyone's going into radiation, make sure you hydrate all day.
okay, thanks, Ross. Steve, Renata, I put a link in the chat window, a Euro Today link. It's a very good discussion between Alicia Morgans, Chuck Ryan, and Chris Sweeney as to why you need to do chemotherapy.
Well, Rick, the last chat window entry I see is MMR mismatch.
Two above that. It's one above that. Oh, sorry, I sent it up. Thank you for telling me. I only sent it to the organizers. My error. I'm glad that we talked. I will try and send it to you. I'll send it to you. I'll send it to you right now. Hold on. Copy. Paste. Everyone. Send. Okay, now you have it.
I got it.
Okay,
Thank you.
sorry about that. I sent it just to the organizers. I meant to send it to everybody. David, you're up.
Okay, thank you, Rick. I'll go quick. This is nothing compared to some of the other things we've been talking about tonight, but I got my second 3-month Lupron shot 3 weeks ago. And more than ever before, these hot flashes and colds are much more intense than before. Is there a reason for that?
It's called progression. And I can't, if you do nothing, I cannot hold out that it's going to improve. Some guys have a really tough time. I had a really tough time. Other guys like Len, it doesn't bother a lot at all. Our best advice, I mean, we've had guys, somebody, who remembers the guy that swore about drinking a glass of cold water? Do you remember that guy who swore that you get it? Drink as soon as you feel it coming on. Drink chilled water. He was from, I forget his name. He was a weird dude from San Francisco. I think that we seem to feel that acupuncture can really help. The problem with the acupuncture is you've got to do it like every 3 weeks. And what I would recommend, David, is that when you're back at Northwestern.
I'm here.
Oh, you're here. So I think they probably have an integrative medicine center.
Mm-hmm.
And they will have practitioners in that integrative medicine center that can administer acupuncture and will know the points for it. If you cannot find, if you're not successful finding that, then at Northwestern, then let's talk, and we need an integrative guy, or we need a good acupuncturist in Chicago.
Okay.
But I think that the first port of call should be ask Dr. Hussein for a referral to the Integrative Medicine Center.
Yeah, she also suggested drink a lot of soy milk or a lot of soy products. But I read about it, and you've got to consume a tremendous amount of soy.
Yeah.
For it to make a difference.
There are drugs. Depo-provera is one. Megace is another one. And there are some people that use estrogen patches, but they all have downsides. I'll send you some information on the drugs. You know, the fallback drug is Megace, but it has side effects, and most people don't prescribe it anymore. I'm not sure I would want to take it. I think if it were me, going through this now, knowing what I know now, I didn't know this back in 2008. I would get acupuncture and see how it helps me.
Okay. Yeah, just for some reason it's gotten much more intense.
Yep.
And
Yeah.
I assume it's from the second Lupron shot, but it's just building is what's happening.
Yeah, it's just building. I don't think it's from the second Lupron shot. Anyone else on the call want to speak about Dennis Correia is, he's one of these guys that doesn't suffer that badly from and never has from hot flushes.
Well, I do get them, Rick. It's just they're not debilitating for me. I could wake up twice a night or so, with a hot flash. And what for me the triggers is any sense of sudden heat. For instance, when my AC comes on, the ducts go through my attic, and the air that's in there is hot. So when it first comes on, before the cool air comes out, there's a little bit of warm air coming out, and instantly that'll trigger it. I'll be driving a car, be fine with the air conditioning on. I turn the corner, the sun is now coming through the window, shining on me. Hot flash.
Yeah.
So it's,
The other thing I tell myself is when a hot flash is coming, the Lupron's working, it's okay. Just take it.
It's lowering your testosterone.
Steve,
a fan also works, David.
Hold on.
A fan blowing on your head.
Jake, hold on a second. We'll come to you. Steve Vanato was trying to get in. Steve.
Yeah, I just want to ask a quick question. David, what were you on before the Lupron?
Nothing.
Nothing. So you just started your ATD.
I did. It was like month 4, month 5.
Okay. All right.
Okay.
So that I forgot. I decided to forgo Lupron for the Firmagon, the Regalix or whatever it's called. But I think at some point I'm going to maybe switch to Lupron because those shots in the stomach are irritating as heck.
Right. Right. I don't want to. Let's not get into Lupron, the Garelix right now. It's a little late, but it's a very good discussion, and you should make a note to bring it up on one of the future calls, next call or future. Jake, what's your? You had a good solution maybe for David.
Yeah, I apologize for interrupting. No, I got used to the Lupron very quickly. It doesn't bother me that much. But I do find when I have them at night, mostly just having a fan blowing on me, even if I have the cover over my shoulders, a fan blowing on my face does help quite a bit. And as somebody mentioned earlier, the water helps. So.
Okay. Thank you, boys. And last thing, next Friday, I'm getting scans. I'm getting a bone scan and a CT scan next Friday. So I'll check in with a full report.
Okay, Peter, you wanted to say something.
Yeah, just quickly, I've heard of guys that had some success by dropping down to 1 month Lupron shots rather than the 3-month shot. That had, extreme reactions to Lupron, just because it's a smaller dose. It's 7.5 instead of the 22.5.
Thank you, Peter.
Okay. David, I'll send you the information that I've got. It's written by a very venerable advocate called Chuck Mack, who most of you here have not heard of. Peter will know him, but he was the go-to advocate for many, many years. And he has written a piece on these drugs. It's a fairly old piece, but it'll be helpful to you. But like I say, see if you can't get something done at the Integrative Medicine Center at Northwestern. They'll be sympathetic. They'll be empathetic, I should say. They may be sympathetic as well, but they'll identify with you. Well, we've lost Paul Frieda. It's 7:23. Before I finish up talking to myself, I think I'm going to have to call this a night. I'm trying to think if there's anything else I need to tell you. I don't think so. Next meeting is Tuesday of next week, which is the 9th, I think. And we'll talk to you then.
Tell them about your thing on the 4th.
Oh, did I not mention that? I think I might have mentioned it at the beginning. Did I not?
You mentioned it briefly, but they need to sign up for it, I believe, correct?
Yeah. I mean, if you would like to hear me, you're probably tired of hearing my voice. So, but if you're not and you want to hear me waffle for an hour on virtual meetings, and especially virtual support groups are good, and the tricks of the trade behind what you see, like the rude notes that I send to Peter and to Jake during the meeting. On the 4th, Thursday, I am doing a webinar with WeGo, and you can listen in. And if you want to sign up for that, I think it was in the letter that I said, the reminder I sent out. It's certainly on the Facebook page. It's on the Twitter page. And if you're really interested and you can't find it anywhere, send me a note and I'll send you the link to sign up. Anything? Joe, Joe Merger, your hand went up. Was that just in? Oh, it was like this. Okay.
Stand bye-bye.
All right. Good night, everybody.
Good night.
Good night, everybody.
Good night. Good night.
Goodbye.
Goodbye. Goodbye.
Good night.